myself Dr. Ayushi Gaudani, and Know Your Calling is a little venture by a team of residents and medical students who this is for budding aspirants who wish to choose a branch for who is what is their calling, and also to clear any doubts regarding the branch. So today's branch is radiology, and to give insight about it, we have here Dr. Zainab Vora, who now needs no introduction whatsoever. But there are so many feathers in our caps that we have to acknowledge that. So today's guest speaker is Dr. Zainab Vora, and she is MD Radiology from AIIMS Delhi, AIIMS PG rank 1 and NIMHANS rank 1 as well, and national level faculty in Unacademy and Prep Ladder, and altogether an institution in herself with thousands and thousands of followers who religiously follow her, including me, and a fellow Gujarati, and also not to forget a doting mother. So please introduce yourself, which is.
Thank you so much, Dr. Ayushi. That's very, very kind of you. I don't think anything else is left. As of now, only the last part is true. I am just the most important priority in my life is being a mother right now. So that is something which is defining me at the moment more than anything else. But thank you so much. So I think it's a great initiative by you guys because knowing what branch to take is one of the most important professional decisions that you're going to take in your life. Only second perhaps to choosing your life partner, because this is going to be taking equal time out of your life, if not more than your life partner. So taking the right decision as far as the branch is concerned is extremely important. And there are people who go wrong, and then obviously some people continue and compromise, some people leave and again give another exam attempt. So I think making an informed decision in the first place is always a good idea, and given the resources that we have today, the access that we have today to all kinds of specialists, I mean it's a very good idea that the pros and cons going into it. Having said that, no branch is perfect. Everything is going to have its pros and cons. We can discuss radiology today, but all of you guys remember that grass is always greener on the other side. No matter what you take, you'll always one day feel that yaar ye le lena chahiye tha, this would have been better. So that will always be true, and you will always have some sort of regret. But it is important that you continue to focus on the positive and focus on the fact that every branch has its own future, every branch has its own potential. So that is also something that you have to give due regard to when you are choosing your branch of specialty, that no matter what you choose, whether it's anatomy or it's radiology or anything in between, you are going to have a potential future in that, and exciting opportunities in that always await, and it depends more on the person after a point and less on the branch that you have chosen. So do keep that in mind as well. And with that sort of a disclaimer and background, I mean, I think we can start a focused discussion on radiology, but I just wanted to give everybody a heads up that every branch will have its pros and cons, and irrespective of what you take, some days you will regret it, some days you will be very, very happy that you've taken what you've taken. Yeah.
Okay. So yes, ma'am. So focusing on the main part, this is the radiology. That is the dream branch of almost any PG aspirant. We will wake up any aspirant in between of the sleep and ask him what will you want to take in your life. He will say that I will take radiology. So can you tell us about a little bit of general introduction about the radiology?
Yeah, so see, again, that statement that anybody would want to take it, I think that is more of a biased decision, because we have seen toppers take radiology, through the years. So somehow that decision is kind of biased, that chalo sab le rahe hai, to it must be good, it is that impression. And if you're taking it for that reason, I would advise you not to. So do it for the right reasons, like we would be discussing. So if I have to give an introduction to the branch, it is again radiology, something we do not get a lot of exposure to during our MBBS days. In the best of institutions, I think like at AIIMS Delhi, in our undergraduate days, we have 7 days of rotation in radiology, which is obviously not enough to know anything about a branch, especially when you want to do it for the rest of your life. And I'm sure the same is true for others also, that you do not know much about radiology. It remains in the black and white, throughout, no pun intended. So, so it is very important to know why radiology has its perks and why it is so sought after, to say. So basically, what a radiologist does is a lot of things. It's a very, very flexible branch. So you have a lot of options as to what, you can do. You can work in a hospital setup, whether it's a government setup or a private corporate setup, and you will be involved in the patient management in every single department. You'll be doing all kinds of modalities from ultrasound, CT, MRI, X-ray, sometimes PET scan, nuclear medicine also handled by the radiologist in certain hospitals. So that is all the modalities, that you will be involved with as far as the diagnosis of the patient goes. The other thing that you can do as a radiologist is the very, very exciting branch of interventional radiology, which is, I think, the future, that is the future of radiology in a very, very big way. So that gives you a very, very exciting life. Something, if you have a surgical bend of mind, something that should excite you is interventional radiology, wherein, through the femoral artery, you can access basically anything that you want in the body. And now so many things are getting done, not just embolization, not just stenting, not just angioplasty. We can basically treat tumors. So many, potential avenues are opening up through interventional radiology. So that is very, very exciting. If you want somewhere in the middle, there are non-vascular interventions that, you can do, like ultrasound guided biopsies, FNACs, RFAs. So basically, that is the purview, that either you are or you are a diagnostic radiology, interventional radiology, or somewhere, in the middle, you're finding a balance. So that is, what radiology basically entails.
Yeah, that's very well said, ma'am. And so, starting from the journey itself, that is the residency period.
Yeah.
So, residence radiology, particularly, is considered a little bit of less hectic branch than the
Mm-hmm.
others. So,
Yeah.
what's your take on it, and what would you say about your life as a resident, and especially in the first year of residency?
Yeah, so definitely if you compare it with your clinical colleagues, your residency, definitely your first year of residency will be a lot chiller than them, right? You won't be up for 24 hours doing the scut work. You would basically be doing good work, I mean, if that makes sense. And, there is a lot of learning which is involved. Radiology has a very long learning curve, if I can say, and definitely it will take at least 3 years of your life, to feel slightly confident that, okay, I think I know radiology a bit, right? So it does take a lot of learning, and 3 years, yeah, is good enough time, but you will need more experience as well. So in your first year of residency, you usually get rotated in all modalities. Like if I can talk about my residency at AIIMS, we usually have these postings wherein we will have posting in ultrasound, we'll have posting in X-ray, CT, MRI, interventional radiology. Then there are certain areas like cancer, onco-imaging, so there are certain other areas like breast imaging, women's imaging, gynae obs. So all of these are the various subparts where every month, you get rotated. So during that time, you spend time with the seniors, you learn, the basics of every single modality that is there. And that is the first year. Then in the second year, you go through the motions again. And so in the final year, so every time you go there, you are a bit more experienced. The first time you are there in any modality is more like an introduction. After that, you start reporting cases more confidently, and in the final posting, you almost work independently as a junior resident, right? So you basically will have other junior residents under you, so you kind of teach them, and you are, the senior one who's going to take care of the scanning and the reporting as well. Otherwise, if I can take you through a day of a resident, so usually The scanning will get complete by the afternoon, 1 or 2 o'clock. The scanning gets completed. After that, all the residents usually get together and we will report the cases. That is the best time, I think, to learn also, because we'll keep seeing each other's cases. We'll keep asking questions to the seniors that, okay, what does this finding mean? What are you seeing here? And you keep showing each other findings, the interesting cases which come along. So the reporting goes on till the evening, 6, 7, 8. There's no limit. It's up to your shraddha, how much you want to spend time in the department. So it's always a good idea to stay back and learn and see more and more cases, because that's where the learning usually happens. We have that feeling, ever since our PG days, that I have to go home and start studying. We have that nagging feeling in internship ki ghar jaake hostel jaake padhna hai fatafat. That is not the case in residency, or at least you should not have that feeling, because the maximum learning is going to happen on the job, rather than the books. This is true for all departments, that the maximum learning happens in the department while doing the job, from your seniors, from your faculty. That is where you are going to learn, and not from the books. Books are only going to supplement your knowledge, your theoretical knowledge, but the most important thing will be the practical aspect of things, which you pick up, while reporting, while you are spending time with your seniors learning. So that is very, very important. And apart from that, we have academics. So at AIIMS, we used to have afternoon classes. Every day we'll have one academic exercise. So sometimes it'll be like a case discussion, wherein a faculty will give an interesting case to a resident. They'll describe and they'll correct the proper method of description that you should have. So all of these academic exercise would be there. Journal club would be there. Interesting cases we'll have to show to the faculty. So you will have these academics wherein you interact one-to-one with the faculty, which is also a very good exercise, learning exercise. So yeah, usually these are the things. Initially, you will start off with conventional modalities, right? So that should be your basics, basically your barium studies, your RGU, MCU. Not my favorite, not anybody's favorite. It's the worst part wherein you start to regret. Like when I started off radiology, that was my first posting, which was RGU and MCU. And I can tell you, I regretted every single day that why have I taken radiology, and what came to me that I chose this branch, and what will I do with my life. But then it gets better. Once RGMC is over, then your life gets better once you go on to other departments, So yeah, so you start off with conventional things, a bit boring, like X-ray and barium and all will feel a bit boring and a bit endangered, but then CT and MR comes along, and it becomes more and more interesting, and you will start learning a lot, and you start loving the branch a lot more, because now there's a lot of clinical correlation, and there's a lot of clinical evaluation and contribution that you'll be making. So that way it's very, very interesting.
Okay, ma'am. Yeah. So after moving on, so after you made the decision to take the radiology branch, what
Mhm.
all things you discovered that you loved, or the things yet
Mhm.
that you still love?
The best part is that you get to be a part of the patient management in almost all the departments, right from emergency medicine, wherein you'll be seeing, patients of acute emergencies, to, surgical patients like acute abdomen. So you are a very, very big part of the patient diagnosis in all of these cases, wherein you are on your emergency call. You are seeing so many cases, in one night you'll be seeing like hundreds of cases of, different diagnoses, gynae emergencies, so emergency aside, you see a lot of interesting OPD cases as well, so basically the best part about radiology is you never get bored. You keep seeing new and new cases at a very, very rapid rate, which is faster than any other, branch, that you get exposed to a lot of cases, and the spectrum of cases, and how different diseases will present itself. So that way, from head to toe, to have that systematic approach of what something looks like, and when you have this picture, what are the various differentials that you need to rule out, what will be the clinical things you want to ask the clinician, and that will help you narrow down your differentials, so that a diagnostic algorithm is something that I love about radiology, that you get to play house, if you know what I mean. Like, we all have that fascination of playing house. I think radiology comes closest to it when, you see a picture, you have these 10 differentials in your mind, you keep ruling out, based on history, based on clinical findings. So, that way it's very, very interesting. It's very, very algorithmic and mathematical, in that regard. Provided we have the knowledge. Obviously, the eye sees what the mind knows as far as radio is concerned. So there's a lot of training, that it takes. And that journey is very, very exciting, to learn that process of what will be the differentials of every single thing that you are seeing. And it's never one thing. Like, when we are studying radiology right now, we study signs, right? This sign is seen in this sign is seen as this. No scan comes with a sign written over it that I am this sign, diagnose me. It's never like that. So basically, that entire process of seeing an image, first diagnosing whether it's normal or abnormal, is the biggest challenge. Once you see it's abnormal, all right, what is the abnormality, what is the pattern, what are the things which fit with it, what are the atypical things which fit with it, and what the patient will end up having. That is very, very interesting. Sometimes you get to do the biopsy also of the same patient, if it's an ultrasound guided biopsy. So you go to the, and eventually, if you are lucky, you get a feedback from the pathologist that, okay, this is what you wrote the diagnosis to be, this is what it turned out to be. And that entire learning experience of every single case, of what you thought through the journey, what it turned out to be, and whether it's matching, if it's not matching, why is it not matching, what is the learning you take out of it. That is very, very interesting. Yeah.
Yeah. So yeah, that is a very good explanation, ma'am. But I don't think here anybody can think of any negative aspect of radiology as such. But there is always the other side of the coin. So what do you think, according to you, are the cons of radiology?
Yeah, so obviously there are always going to be pros and cons to everything. Again, as I said, you are an active part of the patient management, but in radiology, the patient does not know that you are actually, you exist. Sometimes the patient does not even know who a radiologist is, and sometimes you'll get from your family and relatives also, if they are from a non-medical background, they'll also actually question you. What are you actually doing? Are you a technician or a doctor? And that really hurts a lot when you get faced with such questions and comments, because what you're doing and you are playing a very big part in patient management, but somehow that gratitude, and that you are not out there, you are backstage all the while, right? So that
Yeah.
kind of patient satisfaction, if you can call it that, is always lacking, I feel, in radiology. So if you are somebody who really needs that interaction with the patient, that communication with the patient, then perhaps you should think of something else other than radiology, because here, yes, always interaction with the patient will remain. It is up to you how much you want to be engaged, but it will never be as much as other clinical departments. Like, you won't be engaged in the patient management, in the patient treatment, and when the patient is going home, he or she perhaps will not uh, take out time to say thank you to you, or maybe, yeah, acknowledge you. So that is something which will be lacking. That interaction and that satisfaction is somewhere lacking, that you are not getting to play a part in the ultimate management or the treatment of the patient, or you are not actively involved. Always you can be more involved if you want, and there are certain cases that we are more involved in, but all the cases it's never possible to be equally engaged in. So that is one drawback of radiology, which is there. Apart from that, you do have to study a lot. Yeah, so it's a very, very theory heavy branch, wherein, as I said, the mind will the eyes will only see what the mind knows, right? So you need to know the facts, you need to know the theory, you need to know the anatomy first, then only you will know the pathology. So it's something wherein you have to know everything about every branch. So it won't be like any other clinical branch wherein I only need to know about my specialty. Here you need to know about everything, from anatomy to pathology to radiology to all the specific clinical branches. So it does take a lot of reading and studying and understanding to do. So that is again something which is, you may call it a con. Basically, it is something that is that it takes. Yeah. So I think those are the two drawbacks which I can think of.
Okay, ma'am. Yeah.
Hmm.
So here, ma'am, everyone in this world is looking for an early settlement only now. So what about settlement in radiology? As in, what about big city versus small city and government versus corporate, or the amount of investment we have to gather for settling up our own center?
Right. So see again, settling is very very subjective, you know. So after you do your MD, it will depend on what you want to do. Like a lot of us do senior residency because we want more experience. So you know, you'll stay back in a government center or in a central institute, and you want to do senior residency. Some people straight after MD, you know, think of going into private or you know opening their own center. So there are three options that you would typically have even after you finished senior residency. You know, there are three routes that you can typically take. One would be to join as a faculty in a government hospital. So therein, obviously, you have no investment. You will be working just like any other faculty. You get paid the same salary that the institute is giving every other department. But the perks of being in a government job is, you know, the satisfaction. First, in the kind of work that you will be doing, that you'll be doing good amount of you know clinical work with good clinical correlation and feedback. The disadvantage obviously being that the pay will always be lesser and it will be fixed, right? It will be a fixed pay that you'll be getting in a government setup. But there are other perks of being in a government job which are always there. Apart from that, the second route that you can take is going into a private hospital, right? In a small private hospital or a large private hospital. Again, in the private hospital, the job profile usually is like that of the government consultant, except that you sometimes you don't have residents under you. So you know, there is less resident teaching which is involved, and there is more of work that you have to do in a corporate setup, because everything you have to do yourself. You don't have residents, you know, underneath you who are doing the reporting. And basically, so in a government setup, you'd only be count assigning the cases that your residents have reported, and you'd be more engaged in resident teaching. Whereas in a corporate hospital, as a consultant radiologist, you have to take care of every single patient who comes to you, right? Irrespective of which modality the patient wants. So that way you are more engaged, I think. In a corporate setup, you have to work harder, you have to work more hours as far as a corporate setup goes. But the clinical satisfaction is very good. You do get feedback from your clinical colleagues. But again, the pay is much better than the government setup. Usually the pay will start off somewhere around 2.5 lakhs, and goes up to 4.5 lakhs, you know, as a plateau. And you know, that is the highest that you usually get as a radiologist. If you are in intervention, then there is no limit. It's like a surgeon, where the sky is the limit as to what you can earn if you are working as an interventional radiologist. But for a diagnostic radiologist, 2 to 4 lakhs is usually the bracket that you get paid in private. After that, the third road you can take is a center, right? So either you can work in somebody else's diagnostic center, or you can open your own setup. So when you go to decide and work in somebody else's setup, again, usually most of the centers would be ultrasound centers, wherein you are doing scans from 9 to 5, you know, typically. Sometimes they also have cross-sectional imaging like CTMR, so you'll be reporting them in between. So center is a bit, I mean, I did not enjoy working in center. I worked there for 1 month and I really did not like it. I will never do it again, because you don't get any sort of setup. I think that is the worst. I mean, radiology has to offer, because there you are working more like technician, and sometimes at the demands of somebody who is not even a doctor, right? Somebody most of the centers are run by people who are not doctors, and they are more concerned about the numbers that you're cutting, number of patients that you are seeing, and the scans that you're doing, rather than the diagnostic aspect of it. And you know, when you want to correlate things with the clinical colleagues, or you know, you want to basically talk to the patient more, find out about the history, usually that is lesser in the centers, and it's more about, you know, getting the scans done quicker. So that is about the centers you work for. In like other center you work for, apart from that, you can always open your own center. That is a bit difficult, you know, once you've come out fresh from an MD degree. I mean, unless you have your parents who already are running a center, I think it's very very difficult to just straight up open your center, because it's very investment heavy. A single ultrasound machine will cost, you know, somewhere around, a good quality machine in today's time is somewhere around 10 lakh, like the minimum would be 10 lakhs to 1 crore is how much it can go up to. So that kind of capital usually, obviously, as residents we wouldn't have acquired. So it's very unlikely that straight up you'll open your own center, but yeah, few years down the line, that is definitely something that you can consider. So you start off with an ultrasound center, and then you can expand to include CT, X-rays, fluoroscopy and stuff like that, and then maybe like 10 years down the line you want MR also. So that is the dream, right? But
Yeah.
so to have your own independence, to have your own center which gives you the liberty to do the kind of work that you want, I think that is the dream for any radiologist, including myself. That is what I want to do, but it's never possible immediately, right? It will be like a stepwise thing that you do uh, eventually. Again, it will depend on the kind of city that you belong to. So if you belong to, like, say, Delhi or a tier 1 city, a Delhi or Bombay, then it's more difficult to open your own center, right? But in tier 2, tier 3 cities, it's easier to open your own setup. So it will also depend on those factors also. um, yeah, and what else? So apart from that, you can work as an interventional radiologist. So in that case, you usually work in a hospital setup, right? Because you'd need a multi-speciality care. So that's almost like a surgical field wherein you'll need ICU setup, you'll need nursing care, you'll need your own wards. So yeah, so these are the things, these are the future prospects that you want. And again, the kind of capital that you were asking would be somewhere in the range of crores, right? So 2 to 3 crores is the minimum investment that you would need to open your own basic ultrasound setup.
Yeah.
Yeah, roughly.
Okay. So yes, ma'am. So in any branch we go, there is always this firing question that comes up, that what is MD versus PhD in this particular branch. So can you think of any one-stop answer to this question?
It, like, I don't think it matters a lot. So all the avenues that I told you which are possible are equally there for DNB as well as MD. The only thing is sometimes the DNB training in certain institutes of our country is not up to the mark, that you do not feel capable enough to get into job directly. You would want to do senior residency from some other institute and maybe get some more experience before you feel at par with the MD pass outs. But as far as the job opportunities go, and the discrimination goes by the job givers, recruiters, I don't think there's a lot of discrimination. Even if you're a DNB, particularly if you're a DNB from a good institute, like we have Gangaram in Delhi. If you're a DNB passer from Gangaram, you are at par with any other MD resident of this country. So I don't think it matters a lot once you finish your DNB, provided you back it up with maybe a senior residency or a fellowship from a good institute, and then you are at par basically with MD. Yeah.
Yeah. Yeah, okay, ma'am. So let's just jump over to the social strata a bit, and not to sound too sexist or so, but women are more capable than men, and so we are given more responsibilities, and we do a lot of excellence in multitasking. So, what is your take on a woman taking radiology?
I think it's perfect. It is very, very good. Like from my recent life experiences, uh, like having turned a mother very recently, now I can actually sing more praises for radiology, because this is probably the only branch which gives you the flexibility of working from home. So since the last 6 months, I've been doing reporting from home. I've been doing teleradiology, and I don't think any other branch would have offered me that kind of a freedom, that you take care of your daughter full time, and you get to be in touch with your job as well. So I think it's perfect for women, and people who want to pursue their passions, who want a good work life balance, is what I would define, rather than taking the gender bias. Basically, anybody who wants a good work life balance, when they want their personal life, the time for their personal life, and you want a good part of your job also to be done. So radiology, I think, is perfect for that, because it gives you a lot of options, like I said. So if you are short on time, you maybe work in a center for a while. You want to dictate your hours, you go to a private center, and you can always dictate your hours, as I'll be here from 8 to 4, I'll be here from 9 to 5, or I'll be here here from 9 to 1, I'll come part time. So you can always define your hours, and you can leave your work at work. That is something which is not possible with all the branches, I feel. So you can't always leave your work at work, and you usually bring it home, and if you get a call, you have to go. Radiology, on the other hand, sometimes, most of the times, if you are a diagnostic radiologist particularly, you won't have emergency calls out of the blue. So basically, that is how it offers you a lot of freedom, first of all, in choosing the kind of branch, or choosing the kind of job that you want, depending on your life at that moment. And secondly, the career options like diagnostic versus intervention will always again help you, in defining what kind of time you want for yourself. So that way it's perfect, because it is, I don't think there's any other branch which is as flexible as radiology is that way. Yeah.
Yeah, okay. So, ma'am, whenever there is this discussion of radiology as a superior branch, no, in whatsoever group, there is always this person who pops out as a hated uncle of the family, that there will be artificial intelligence taking over radiology in few years. So, can you please just give the hit about it?
Yes, yes. I have been hearing this for very long, and I'm very sick of it. So I want to definitely explain this. See, artificial intelligence is something which we have only developed, right? This is only which we have come up with. So it will never be able to replace us. And if I just tell you a basic example, if you ask any patient, or for example, if I ask you, if you are the patient, would you like a report from a robot, or would you like a report which is obviously checked over by a human being, right? Any day you would say that I want it to be checked by a human being. Even if a robot has reported it, you want that a human being has cross-checked it, right, before you take it to your heart. So that way it can never replace a radiologist, so that is just not possible. What AI will do is filter a lot of unnecessary work for us. For example, if I can tell you what the current AI has achieved is, they can actually, for example, you have 1,000 chest x-rays to report in a single day, right? In a hospital like AIIMS, you would easily have matlab 1,000 x-rays in a week, that you have to report. So 1,000 x-rays you have, you tell your AI that please filter out the normal x-rays for me and keep the abnormalities aside, right? So it filters out those 700 x-rays which are normal, and it gives you those 300 x-rays with the probable findings pointed out, that these are the problem areas. Do focus on them, and make sure you're not missing out on them, and what are your probable differentials. So that is what currently we are using AI for, that it basically triages your cases into normal, abnormal, and what are the computer assisted diagnosis that you are actually looking for. So it's actually helping a radiologist be more efficient, and that is always going to be the job profile of AI, wherein it makes my job as a radiologist better, and not replace me. So that is something which is very, very important to understand, that we are using it first to supplement us, basically to make sure we are more error proof, we are not missing out on diagnosis. Secondly, to filter out normal things for us, or maybe to triage that, all right, these are the things which need your immediate attention, these can wait, right? And that is always a good thing for the patient as well as for you, right? So basically those are going to be the areas. Apart from that, AI currently is also being explored for more personal patient management, personal diagnosis and personal management. That is what is the future, wherein we are going to be targeting oncogenes, going to be targeting molecular diagnosis through radiology, which is called radiogenomics. That is the upcoming branch, wherein we want to predict that this is likely the mutation in the lung cancer by looking at various imaging features. So we are going closer and closer to personalized medicine, targeted medicine, and treating that mutation is what is being targeted by the clinical counterparts. So that is the future, and it's very, very exciting. So I want to tell all of you guys that AI is not something to be scared of, it is something to be very, very excited about, and it's only going to make your job as a radiologist much, much better and efficient. Yeah.
Yes, ma'am. Yes, ma'am. So now going on further and having a little bit of French reference here. So as Monica famously says that welcome to the real world, it sucks. So after going to the market, there is always this competition with a person who is not a qualified MD radiologist. So
Mhm.
if there are many obs and gynae people who do a course on USG and do obstetric USGs, and there are many sonography courses here and there who MBBS graduates do, and they do practice at small towns also.
Mhm.
So, is there a thing that we should fear about them?
Um, See, basically, in our country, we are never going to be saturated, right? It's not like that person will take away your cases. There are always going to be enough patients that will come to everybody, you know. And
Yeah,
in today's time, I think the patients are all very, very aware of, you know, where they are going. In fact, they will make a lot of comparisons from where you have done your MBBS, your MD, from let alone, you know, going to a sonologist. So today's patients are very educated, you know, in that regard, that they can take a very informed decision in where they want to go. So I don't think you need to be worried, you know, if you are good at your job, I think that is what you need to focus upon, and not what others are doing. I mean, that is something which is, I believe, very true in general life also, that stop worrying
yeah,
about what others are doing, let them do their thing, you do your own. And you know, patients will come to you if you're doing a good job, I mean. Yeah.
yeah, ma'am. Okay, so for the counseling purpose of NEET PG 22, that is approaching hopefully.
That is
So,
approaching very slowly.
yeah, so what do you think aspirant should keep in mind for choosing the college or hospital?
First is the kind of modalities which are there. So you would at least want there to be X-ray, ultrasound, CT. Obviously, all the hospitals in our country do not have MRI access. If you have MRI, nothing like it. Intervention again is not there. I mean, in a lot of places, you know, very few institutes offer interventional radiology training. So if you have all of these, then nothing like it. You know, go for a hospital, you know, which is giving you the maximum exposure to most modalities. That should be the primary thing. Apart from that, look at the academics that are being offered by the institute. You know, talk to the seniors there. You know, what kind of learning happens, what is the faculty interaction, what is the senior junior interaction, what are the job timings, you know, do they report together, what is the, you know, what is the teaching like, basically. So I think those are the two things. One is the modalities, which will basically, you will be dependent upon them for your learning. And secondly, the academics are what is very important, because as I said, the books, you know, help to a certain extent. After that, the learning, the main learning is going to happen on the job, you know. So basically, ask about these two things, and you know, then choose the college, basically, wisely. Yeah.
Okay, ma'am. So that is the end of our conversation, ma'am, and you have so beautifully, in a detailed and very bold way, explained all the doubts that the aspirants had. And it was my absolute pleasure to have you here, and that's so kind of you, of a woman like you with such a huge stature to give your interview in a very little venture of us.
Thank you
And
so
today I can say that I can sleep today with a huge smile that I got to interview the woman I religiously followed throughout my preparation, and to tell you, ma'am, that I am going to get medicine, which is my dream branch, and all credits to you and your Midnight Express Vision videos.
Thank you so much, and many congratulations to you on doing so well. And it was my pleasure talking to you. And I would be very, very happy to see you and meet you very soon. And thank you so much to everybody who's joined in and listened to our conversation. If you have any other doubts, you know, feel free to comment, and I will reach out to you.
Yeah, ma'am. So, the people who have joined, any of you have any doubt, you can please ask.
Okay, so I think Sneha is asking, can we write USMLE after DNB? Yeah, yeah, you
Yeah.
can write USMLE. You know, I mean, it doesn't matter whether you've done DNB or MD. So yeah, I think we can spend some time talking about the future options also. So USMLE is something wherein you know, you usually go to US after doing your MD or DNB to do a fellowship in US, right? Sometimes you want to settle there, So settling there would require you to repeat your residency in US. But if you are basically going for a fellowship, for that also you need to clear your USMLE steps. So now you need to clear USMLE step 1 and step 2 CK, and then step 3 is something that you have to give for your visa purposes. With these 3 steps, you can apply to any institute of your choice, and usually they will accept the fellowship candidates for a J1 visa, which is a temporary visa. If you want an H1 visa, which is like a harder visa to get through, then you do not get access into a lot of institutes that way. You have to go into the periphery of US. But yeah, if you are willing to go only for a fellowship and come back to India, the best institutes will also take you up for fellowships. So you write your USMLE steps after DNB, after MDS, and then you can go and apply for fellowships into the US, do maybe a couple of fellowships, come back better trained, better exposed. So that way it's a very, very good option. Apart from that, a lot of students also do FRCR. So FRCR is the course which is, it's the degree which is accepted in a lot of countries, including UK, Australia, New Zealand, Singapore, Canada. So that degree opens up a lot of future options for you. So if you want to settle in any of these countries, a lot of our friends write FRCR during the residency itself. It's a bit of a time consuming process because there's usually waiting. So it will take around 3-4 years to finish all the steps of FRCR. So people start off in their first year only. They give the first step in first year, like that. So yeah, so that is also a good option that you can consider if abroad is what you are interested in. Yeah.
Good evening, ma'am. And first of all, thanking this wonderful platform for bringing the goddess herself.
Thank
And
you.
so inspired by your videos. I have been there since the starting of the MER, and I really hope my journey would end with the MKTs. And
That's good.
you have answered most of the questions really well, and
Mhm.
I'm satisfied with all of those questions that Dr. Aishi has put up.
Mhm.
But one more thing I would like to add here is, um, for example, as we know that how respiratory medicine can open gates to DM cardio or DM critical care medicine oils. How does
Mhm.
MD radio can open a door to other branches, or how can it be a bridging branch, to relating with the other?
Yeah, so I mean, you cannot obviously cross over into other branches with radio, but the kind of fellowships and DM courses which are there, there's always going to be a lot of clinical overlap. So if we take into account, say, interventional neuroradiology, right? So IR basically plays a very big role in that, wherein you will have neurosurgeons also, who are working alongside you, with you. So vascular neurosurgery and vascular neuroradiology basically go hand in hand. So that is one branch where there is a lot of overlap with neurosurgeons. Apart from that, cardio radio as well. So when you're doing vascular radiology, again you will be in touch with your CTVS counterparts a lot. When you're doing aortic interventions, thoracic aortic interventions, there's a lot of overlap. Apart from that, I think Dr. Dheri is also asked about the various other fellowship options. So, I mean, just to combine both the answers. So, these are the DM options. Apart from that, we also have DM in IR, which is there in a lot of institutes now. So, again, interventional radiology will require that further 3-year study after your MD is over. So, that is definitely a requirement if you want to go into IR. Just a fellowship doesn't suffice anymore. So, I think AIIMS Jodhpur has it, TMC Mumbai has it. So lots of places are now offering DMIR as well. Apart from that, fellowships are so many in radiology. The best part is, you can choose your interest and, you can pursue a fellowship in it. So from pediatric radiology, GI radiology, and thoracic radiology, these are the 3 fellowships that we have at AIIMS. Apart from that, I think throughout the country, there are so many others. So including fetal imaging. Again, fetal imaging is one area where you will be in touch with your obs and gynae counterparts, They are also kind of learning it with you. So fetal imaging is very, very important, and it's a very interesting branch which is there. So you can also venture into fetal interventions, after a while, doing amnio, choriocentesis and everything with your gynae colleagues. So that is one fellowship option. Apart from that, cross-sectional imaging, onco imaging, You have what else? So many fellowships are there. Cross sectional imaging modalities are there. MSK fellowships are there. Women's imaging. So there are too many fellowship options, out there in various institutes. Yeah.
So basically, instead of having the patient satisfaction, we are having our peer satisfaction, because every time we are going to intertwine with all the branches and with all our peers, it seems.
Yes, yes. So that's why, radiology basically, our patients are not patients. Our patients
Yeah,
are doctors
doctor.
only. Yeah, coming to us. So you are a doctor's doctor basically as a
So
radiologist, and
true.
patients somehow will never know that you exist.
So true. Thank you so much, madam, for answering all these questions really well, and looking forward for more.
Yeah, yeah, absolutely. I think Akansha also has raised her hand. Maybe you can put her through.
Yes, Dr. Akansha is
Hi, Zainab
Hi,
ma'am.
hi
So
Akansha.
good to see you.
Yeah,
And
same here.
you've always been an inspiration. And I saw Ravi sir also, like some days back. I was in AIIMS in Delhi, so
Yeah,
I
yeah.
saw him in the campus.
Oh yeah, you are a very big celebrity right now. So very nice. What did you eventually decide? What are you going to
No,
do?
ma'am, I'm deciding to pursue radiology only because I
Hmm.
listened to what you were saying about the
Yeah,
flexibility of the branch, which
yeah.
I mean, surgery requires a lot of dedication, and
Hmm.
for females, it is, it does take a bit of things become a bit
Yeah.
difficult for us.
Yeah, I
Uh,
mean, if you see, radiology works very well because if you do have a surgical bend of mind, you can always pursue IR, and that
yes,
kind of your mind gets satisfied with, IR for sure. Basically, it's equally thrilling, equally, bringing you adrenaline rush. If that is what you're looking for as a
yes.
surgeon, I think IR is something that does a very good job at bridging that gap.
So, ma'am, my doubt was regarding the earnings of intervention radiology because the DSA guided interventions will require a setup. For
Hmm.
example, what you mentioned, and then again, we won't have the patient under us, like
Hmm.
somebody would be referring to us.
Hmm.
So, when you, with respect to earning potentials, is it that the ultrasound CT guided procedures, if I do on a day to day basis, will be more
Hmm.
rewarding in terms of money as compared to doing DSA interventions?
So see, it will depend. Like
Okay.
opening your own IR, DSA IR setup is
It's very
very, very good.
difficult,
Right?
yes.
It's almost like opening your own neurosurgical setup. It's never
Yeah,
possible
never
because you need
possible.
a proper dedicated ICU setup. You need a ward setup. You need those specialists looking after your patient. So without a multi-speciality hospital, an IR setup will not be able to exist. On the
Yeah.
other hand, an ultrasound or a CT guided intervention setup is definitely possible. In fact, if you have your own ultrasound center, you can definitely combine it with a biopsy or an FNSC center. Maybe you are doing RFAs and you add up from there. Maybe you add a HIFU to it and start doing HIFUs. So, you can always complement that. That is always an easier option to open single handedly or, with lesser clinical support. Obviously, in these also you would need backup. You would need clinical backup and a hospital backup in case of complications. But that is always something which you can perform standalone with just backup. Without your own hospital setup. Uh, so that is very good in terms of earning also because these intervention charges again have no upper limit. It will depend
Correct.
how good you are as an interventionist and how well you are doing these procedures, then patients will come to you basically because not many people are doing these biopsies outside. If you look at any like usual diagnostic centers, they are not doing interventions, they are only doing scans, right? So if you can basically open your own setup and start doing these interventions, if you're well trained in them, then there's no limit to the amount of money that you can actually earn these, and you won't really need DSA to
Yeah.
earn money. That is what basically that is what you're looking for. But obviously, if IR is what you want to pursue, then it's better to pursue it in a multi-speciality hospital, is what I believe, rather than opening your own setup. Because at least,
Okay, ma'am.
yeah.
And yeah, one more thing I wanted to ask is like in AIMS when I was working in surgery, we used to get a lot of procedures done in radiology for
Mhm.
biliary procedures for
Mhm.
PTPD and all.
Yeah,
We
yeah,
used to
yeah.
get it done. So for like if I want to learn those kind of things, what should be my approach? I mean,
See, there are a variety of non-vascular interventions which we can do, right? So the kind of procedures which you are talking about are all fluoroscopy guided
Yes.
procedures, right? So you would need either a C-arm or a fluoroscopy unit for them. So you have biliary interventions, you have renal interventions like PCN and PTBD are two of the most, commonly
Yeah.
done procedures. You have central lines that you can put. So all of these are fluoroscopy guided procedures. So again, these are things that you can do with a good enough clinical backup. You cannot do them in your own center because again, you need clinical backup, but you can do them in a small hospital for sure. These are not things which require a lot of training like IR. These are things like which I am very confident of doing if I've done my 3 years of MD and 1 year of senior residency. If I've done that and I've done enough procedures, just going out of it 4 years, you are confident enough to be doing them independently.
Ma'am, so actually a lot of colleges don't have this kind of fluoroscopy setup
Hmm.
also. So
Hmm.
my last question was that only, is it difficult to get into such kind of fellowships which offer you such kind of training, especially if you're not in AIIMS Delhi?
Yeah. So see, no, there are various fellowship options. Like you have ILBS, uh,
Yes.
you have AIIMS Jodhpur, which is offering a fellowship in GI. So
Even AIIMS Rishikesh also is there.
yes. So you have GI hepatobiliary fellowships. If you get into it, you will definitely be learning these non-vascular interventions. In fact, you'll be
Okay.
learning a lot of vascular interventions also, but non-vascular you'll be very confident of, right? So basically, 1 year of fellowship will also do you good as far as these interventions go. ILBS is a very good place where you
So it's not difficult to get in over there. That's
no.
what my question
No, no, no. See, there are so many options, no, for fellowships that it is not difficult. I
difficult.
feel, yeah,
Okay.
if you can get into radiology in a good institute, I mean, fellowship is only easier.
Okay. Thank you,
Yeah,
ma'am.
yeah.
Thank you so much, ma'am, for
Mhm.
clearing my doubts.
No problem. All the best
Yeah.
to you.
Thank you, ma'am.
Okay, ma'am. Okay, ma'am. So yeah, thank you for uh, giving us the interview and
No problem.
so
All right.
going
So,
on.
thank you so much,
Yeah,
Dogan.
ma'am. Okay, ma'am. Good night.
Good night.
There are many 25 more videos of other branches also. So you can, all the viewers can just subscribe to our YouTube channel and also follow us on Instagram. Thank you.